and welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
We have a wonderful article to discuss on the podcast today that is titled Gait Features of Dystonia in Cerebral Palsy. This article was recently published in Developmental Medicine and Child Neurology, and we have the lead author, Dr. Bhooma Aravamuthan, joining us on the show today. Welcome, Bhooma.
Hi, thank you for having me.
And welcome, Dana.
Thank you very much. I love being here again. Well, Bhooma, thank you so much for being here today. We have absolutely loved your article. We just love the methodology. It's so innovative. We love the topic. And between the two of us, we're a little bit giddy with excitement.
Yeah, absolutely. As a qualitative nerd, this paper has a really strong qualitative component to it. So I am really excited to get into this today.
Thank you. Me too. I should just keep you guys around. You're a huge ego boost.
Well, congratulations on such a great paper.
Yeah, and we know all of our listeners are really going to love this conversation about your article today as well. Before we get into it, though, we just wanted to give everyone a little bit of background about you, Bhooma, who you're an assistant professor of neurology and pediatrics at Washington University School of Medicine in St. Louis, Missouri, all the way in the USA. So there's a bit of a time difference here today. And when it comes to expertise in cerebral palsy and pediatric movement disorders, particularly with dystonia, Bhooma is really widely published. Her recent work demonstrates her broad collaborations with leading experts in the field, and we feel very privileged to have an opportunity to speak with her on the podcast today. So before we get into it, Bhooma, you might have listened to the podcast before, but if not, we traditionally have a little bit of an icebreaker question to get things started. And the one that we thought we would ask today is, would you rather travel 100 years into history or 100 years into the future, and why?
So this is, you may not have known this. This is actually a pop culture interest of mine. I like watching a lot of TV shows with time travel. So I would definitely do 100 years into the future, because I would worry that if I went 100 years into the past, I would change something minuscule that would screw up the present. So definitely 100 years into the future to avoid messing up the present.
Oh, I love that.
So
good
sensible.
Sci-fi chick.
Yes.
I like it.
That hadn't even crossed my mind. I have not watched enough sci-fi.
This is why we have people like Bhooma in this world, to keep everything in balance, Ash.
Well, I was also going to say that I'd travel 100 years into the future, but not for reasons nearly as thoughtful as that. I'm just really nosy, and I'd like to know what this kind of state the world's going to be in, knowing that I could come back to the present safely and maybe bring back some cool, inventions or ideas that we could use today.
See, that's a good one too. I think we've all decided to go into the future here, because I'm definitely going to be future driven as well. And the main reason for that is, do you remember growing up, this will show my age, but we used to watch the Jetsons, and there were flying cars, and there were just great things happening. And I love Back to the Future. I love the whole idea of that, going into the future, bringing something back. But I think going back into the past might be a bit scary, just because we have a lot of modern technology that I'm really used to. I'm not sure if I'd cope particularly well.
And I suppose at the time that we're talking now, 100 years in the past wasn't necessarily a great time to be alive, was it?
Probably not. Let's go into the future, forward looking.
Yeah. But we'll come back to the present now and talk a little bit more about your paper, Bhooma, because as we said, it's a really cool paper, and we're really excited for our listeners to hear more about it today.
Alrighty, well, let's get into the specifics of the paper. So this is really a unique article and such an important piece in describing movement features specific to identifying dystonia in children with cerebral palsy. So the objective of this work was to characterise the features of motor phenotyping from clinical experts in identifying dystonia in people with cerebral palsy. This was done using a qualitative study utilising thematic analysis in order to analyse consensus-building discussions of paediatric movement disorder specialists as they assessed Gait. So they had a panel of 3 experts reviewing Gait videos that were taken in their clinics retrospectively. And within this, 40 children aged between 6 and 24 years, with a mean age of 13 years and 4 months, with cerebral palsy and periventricular leukomalacia, or PVL, classified within GMFCS level 1, 2 and 3 were observed. So the Gait videos involved the child walking down a hallway, and this ranged between 2 and 24 seconds in total. So here are the results. Of the 40 videos, 30% of videos reached consensus before consensus building discussions. And after the discussions, experts agreed on 85% of the videos of whether dystonia was present or not, highlighting the importance and significance of consensus building discussions. However, with the 15% remaining, they did not receive any consensus. So the qualitative thematic analysis revealed a body of codes that derived 2 very clear themes. The first theme revealed the difficulty of diagnosis, while the second theme highlighted the features of dystonia, which included variable unilateral foot and leg adduction as a commonly cited motor feature. So this work really highlights that it is possible to codify the subjective process of expert consensus. This not only serves to supplement standardized assessments and scales and diagnosis, but it also provides clinicians with some really useful tools that brings clinical expertise straight into their own practice. And it really does open up the door to other possibilities when it comes to broader diagnostic applications.
Thanks, Dana. That's a great summary. And Bhooma, as I said earlier, I really enjoyed reading this article because of the really strong qualitative component there was to it. And perhaps you could start by explaining for our listeners who maybe aren't as familiar with qualitative work, the process of codifying the expert consensus and building the framework for those discussions. Could you tell us a little bit more about, the qualitative thematic analysis?
Yes, absolutely. So the value in qualitative thematic analysis is the ability to characterize in a systematic way really rich data that involves people talking, people speaking, people discussing their ideas. And that isn't readily measurable without really delving into what is said and thinking about what are the specific ideas or codes that make up the overarching ideas that contribute to a discussion. So the process of qualitative thematic analysis, or the process of thematic analysis that we employed, we recorded consensus building discussion between experts, pediatric movement disorders physicians, as they discussed whether or not dystonia was present or absent in these subject videos. And we then had 2 coders, quote unquote coders, look at the transcribed version of those discussions. And for each statement that was made, break down each statement into individual ideas or codes. So the statement where one of these experts may view a video and say, I don't know, I think maybe the left foot comes in a little bit. It's hard to say. So that's an example statement. So the statement, I don't know, I think maybe, those are representative of uncertainty. The left foot, so the idea that either the left or the right foot is focused on, that was the unilateral code. Mentioning of the foot, so a foot or a leg mention, those were individual codes. Comes in, that comes in was the adduction code a little bit. That's a code that signifies subtlety, the subtlety of these movements. And then I think at the end of that quote, there was another expression of uncertainty. I don't know. So that is a classic characteristic statement that was made by experts as they describe these videos. And you can have coders break down those statements into those individual ideas. Then you can see how frequently those ideas are espoused as you move through the discussion, and look at how those ideas segregate together into themes and how they segregate differently based on whether experts are seeing dystonia versus not seeing dystonia.
And I really one of the main takeaways I had from this paper was that, traditionally in qualitative work, often we would build an interview guide and we would have, questions that we ask of people, and we would use that information to, and the transcripts of those interviews to build our themes and our common codes. But what was really cool about this paper was that you were privy to something that happens clinically anyway. Those consensus building discussions are something that would happen within the clinical setting regularly. So it was really nice to have that insight into how those discussions typically pan out and the themes that are generated as part of that.
Thank you for saying that. And I find that to be really interesting, that in a lot of thematic analysis work that we're really interested in understanding what our patients are thinking and their decision-making process, and not necessarily analyzing the rich qualitative data that we have as a part of, as medical practitioners that we engage in as a part of our day-to-day clinical assessments. And I think we have this idea, you just have to have the experience, it when you see it. Diagnosis comes from experience, but everything we do can be analyzed as well.
Yeah.
So, thank you. I appreciate you saying that.
Yeah, that is really cool, because I think when it comes to this topic, and you've picked the perfect methodology and approach for this particular topic, is how many times do we hear that in dystonia? Dystonia, you've got some great definitions here, which I know are the consensus sort of international statements of what dystonia is. And I want to go into that in a lot more detail because of your breadth of expertise. But before we even go into that, it's worthwhile noting that a lot of clinicians have a lot of difficulty in noting what dystonia is, which is what your results say. But it's always about sitting around some experts and thinking about what it is and discussing it. They're really robust discussions. And the fact that you've done what you have done, you can see the knowledge translation so readily available to us. So I think that's why us as nerds, we're so nerding out right now, and we just absolutely love it.
And just on that, I suppose, we're seeing an uptake in scientific journals, publishing more qualitative thematic work. But one of the strengths of your paper was the key features that you applied to actually increase the robustness of what you were doing. So addressing those threats that we commonly see to validity and bias in qualitative work. Could you describe briefly, I suppose, how you ensured that there was, a valid and reliable results in what you were producing?
Yeah, absolutely. I'll try. So one of the things we did was we made sure that the coders were independent. And this seems like a no-brainer, but we made sure the coders were independent of the discussion entirely. So they weren't present for any aspect of that initial discussion. They didn't participate in it. Yeah. They viewed the transcript separately. They came up with codes independently. So they both coded the transcript separately. We reviewed those codes together, came up with a set of aggregate codes that both of those coders agreed on. Then they recoded the transcript with the aggregate codes. So there was agreement. And then we only used the codes that those two coders agreed on. So if there was a part of the transcript that was not that was coded by one person, but was not coded by the other person, we didn't include that in the final analysis. And then after we looked at how that transcript was coded, then you have some quantitative data from the qualitative input. Yeah. So then we could do analysis of the frequency with which these different codes ebbed and flowed through the discussion. And we looked at how that frequency distribution changed as depending on whether the video discussed was ultimately identified as having dystonia or not. But it took a lot of effort at the outset from our coders, Sarah Smith and Laura Gilbert, who did a wonderful job with their coding.
Wow. Yeah, the thematic analysis on its own is a lengthy and complicated process, but to add that kind of the time component onto it as well, I imagine increases the complexity tenfold.
Absolutely. And we know that a lot of clinicians talk a lot as well. So that's was a lot to probably go through. Oh, wow. Okay. So now, Bhooma, you as a neurologist working in this area and especially movement disorders, I thought it would be really great for our listeners to be really up to speed with regards to the definition of dystonia. And I thought we could start there as a first point. So can you just describe to our listeners, what is the current definition of dystonia?
Sure. So dystonia is classified as overflow muscle activation that's triggered by classically an attempted voluntary movement. That's the crux of the definition from Albanese and others that was published in Movement Disorders at this point close to a decade ago.
Mm-hmm.
That the difficulty with that definition is that is also its beauty in that it is intentionally vague about the characteristics of the movements that can make up or that can be called dystonia, because it has to be.
Yeah.
Because dystonia can look dramatically different depending on the type of voluntary movement that's triggered it, depending on the limb involved, depending on the etiology. And this definition does an excellent job of talking about what the trigger is and that an involuntary movement occurs because of that particular trigger, but leaves it up to the eye of the beholder in terms of what the specific movement looks like when classifying dystonia, which is great for an inclusive definition, but is also difficult for practitioners to put into easy practice when trying to assess dystonia in their patients.
Yeah, because it's such a visual thing to be able to see what it actually looks like, isn't it? So I guess from there then, from that definition, I know there's been a lot of work in developing scales to be able to describe it. I know you mentioned the dyskinesia impairment scale. There's the hypertonia assessment tool. I'm quite aware of the Barry Albright scale, the BAD scale, which is probably not a great acronym really. So can you talk us through about the context of the good scale? Yeah, let's turn that one around. Sorry, Barry Albright. So how do we use those scales in the context of the definition of dystonia?
Yeah, so the great thing about so let me start with the hypertonia assessment tool, which is an amazing tool and really helps differentiate between the presence or absence of dystonia, spasticity, and rigidity, the three forms of hypertonia. It relies on the observer to be able to detect the abnormal involuntary movement in response to a trigger, in the case of the items corresponding to dystonia, which is a huge step forward because you're instructing the practitioner that you need to see if there's an involuntary movement that's triggered by something else, which is great. But a lot of the involuntary movements can be quite subtle, or it can be in parts of the body distal to the one that the person you're examining is moving. So you can miss dystonia that's elicited during that tool. Although it's amazing just instructing people to employ a trigger on exam, what that can do. The DIS and the BADS are great at describing the almost the functional impairment associated with dystonia. But particularly for the limbs, the instruction of what specifically to look for, what position might an arm or a leg be in that would signify dystonia, that would make you start thinking, okay, I need to grade the severity of this. That particular instruction is lacking. And again, it has to be because dystonia looks so different based on the context and the person. So great tools, great scales, but there's still that requirement of the clinician to know what dystonia looks like in order to employ them.
Sure. Yeah. So you can really see where this work comes in. So I guess in terms of dystonia and cerebral palsy within that context there, what is the incidence of dystonia? Obviously we know spasticity is often what we talk about, but we know it also there's, comorbidities with dystonia. So how frequent do we see dystonia in children with cerebral palsy?
So it's a great question. I think classically we cite this figure that spasticity predominant cerebral palsy is the most common form of cerebral palsy, affects maybe 80-ish%, and that the dystonia predominant form of cerebral palsy affects maybe 13 to 15%. And that's kind of the number that a lot of us carry in our heads. But there was an amazing paper published by James Rice with Darcy Failings a few years ago that used the hat to identify dystonia in people with spasticity and cerebral palsy. And they found that 75% of people have some degree of dystonia, particularly in the legs. So I think we talk about categorizing CP as you're mainly spastic or you're mainly dystonic, but we know that most of our patients with CP have mixed tone. And really thinking about dystonia in that context is valuable. Dystonia doesn't have to be your primary feature in order for it to be functionally limiting for you. So, and there are up to 75% of people out there with CP that have some degree of dystonia. And I bet far more than 15% of them are functionally limited by it.
Wow, that's a high figure. And I think more and more as we're looking into the statistics and we're looking more into cerebral palsy, we're realizing that it's more about a Venn diagram and how much overlap there is, isn't there? You know, we spoke a little bit about the co-occurrence of ADHD, autism, and intellectual disability occurring in 2/3 of children with cerebral palsy. And you kind of go, okay, so now when I'm approaching cerebral palsy, I am going to be thinking about these other factors. Now, when I'm thinking about movement and I'm looking at children with cerebral palsy, I've got to consider dystonia as a possibility in the way that they're moving and might be functionally limiting for them.
Yeah. And so,
yay, that's the take home.
Hooray, job done. So, Bhooma, why is it so important to identify and diagnose dyskinesia in children with cerebral palsy?
Yes. So, for a few reasons. The push to diagnose cerebral palsy earlier and earlier is a good one. We have data from the Canadian Cerebral Palsy Registry that children that have a predominantly dystonic motor phenotype compared to a spastic motor phenotype may have disorders that don't necessarily fit in the CP umbrella that would require different treatment to be instituted early. So I say this because identifying dystonia at the outset is important. I know that we've all had a lot of patients who have come to us at 18, 19, and they've never heard the word dystonia. And then you say, oh, you have dystonia on exam, and they're shocked. Wow. They've never heard it before. Nobody's mentioned it to them. And you think, what's the big deal? You identified it at some point, you can treat it then. But early identification can really change the entire diagnostic and treatment trajectory for some children. Yeah. And some children could have access to potentially curative treatments early on, depending on the type of disorder they have that's causing predominantly dystonia. A little bit later on in childhood, we do have good data, particularly from deep brain stimulation studies, that the longer you wait, the greater the proportion of life lived. And this is from a paper by Lumsden and colleagues, J.P. Lynn's group. The greater the proportion of life lived with dystonia, the worse the outcome with regards to deep brain stimulation, meaning that, again, identification of dystonia early could actually lead to better treatment outcomes in people with dystonia and CP. And the medical treatments for dystonia are also quite different from the medical treatments for spasticity. And there was another great paper out by Darcy Failings' group that talk about the range of medical treatments for dystonia that you might not consider for spasticity, like clonidine and gabapentin may not be your choices for spasticity. So I could go on and on. There are so many reasons from a treatment and management perspective to identify dystonia. Maybe one of the other overarching reasons is to explain to families and to the patient in front of you what's going on with them, putting the accurate label on the issues faced by your child or by you can in and of itself be therapeutic. People, you see the light bulb go off in their heads, and that is and the breath they've been holding in is let out, and you see the value in that. So that, in addition to all of the other things, I'll think of more things.
And I think it's such a true point, because if we're not specific with our language in what we're seeing, then we're not also really just helping families to understand what's going on in their child, or for the person to understand what's going on in their body. Because we do talk a lot about dystonia and the relationship that it has with function, but there is also pain that is quite prevalent with dystonia. Can you talk us through a little bit more about pain and dystonia?
Yes. Yeah. So a lot of people with dystonia deal with pain. There is data, I think, again, from JP Lynn's group that talk about how pain is much more common in people with dystonia predominant cerebral palsy than spasticity predominant cerebral palsy. And pain and dystonia can be quite a vicious cycle. So I talked about voluntary movement trigger for dystonia. That's part of the classic definition. A heightened state of arousal can also be a trigger for dystonia. That includes stress, illness, and pain. And if your dystonia is causing pain and your pain is triggering your dystonia, what an awful cycle to be in.
Absolutely.
So thinking about screening for pain, number one, asking people with cerebral palsy across the board, not just with cerebral palsy and dystonia, is your child in pain? Do you feel pain? Where? When? And then addressing that pain can be really valuable.
And I think pain is such an important discussion, because I know that there's an increased knowledge now that pain is something that we should be considering in our treatments. And I know Darcy Velling's group as well, we're mentioning her a lot, because they've done a lot in this area of dyskinesias and pain. And I think this just really drives home for clinicians who are listening in when they are treating children with cerebral palsy, yet we need to be thinking about dystonia. We need to be thinking about what this work means in identifying, because our observations of what's happening at home, in the community, can be really useful for a physician who isn't within the hospital to be able to know this kind of information, contextualize it, because then it will really influence treatments. Like, I'm sure that's really valuable for you. Wouldn't it be, Bhooma, in clinics?
Oh, absolutely. Yes. The more information you can have about how each of these issues affect someone on a functional level and on a day-to-day basis, the better you can tailor treatments to that child or to that patient in front of you. And just overall, the better you can address their concerns. I mean, making sure you know what how each of these diagnoses are affecting the person in front of you is critical, and pain is a critical portion of that. Absolutely, I agree.
Absolutely.
So should we dive into some of the results of this study now? Because I feel like we've done a really good job of setting up, I suppose, the bigger, broader context for it. But I'd love to talk to you about some of the specific, I suppose, codes and themes that were derived from those clinical consensus building discussions in this paper. And so you just touched on, the idea of movement and this theme that emerged around unilateral and variable foot or leg adduction. Could you describe this a little bit more for us, and why you saw more unilateral, even if the clinical exam is focused on the bilateral movement?
Yeah, weird, huh? We were surprised by that.
Yeah.
So looking at the discussion, it wasn't that in any given video that only the left side or only the left foot was dystonic. It was just that at any given time in this motor task, Gait, where you're alternately activating your left and your right sides of the body, you would only see dystonia on one side of the body, on one leg or one foot during this particular motor task. So I think I don't want to give the impression that children who are bilaterally affected with bilateral cerebral palsy tend to have unilateral dystonia. It was just that with this motor task, the way that dystonia manifested at any single given point in time was unilateral.
And what phase of the Gait cycle did you tend to see, or did they tend to kind of bring this up? Were you able to tease that out at all?
So we did not look at that specifically. I think that's a great question. And I think that could probably also be applied to a lot of the gait analysis, the formal gait analysis that's done in these children. But we didn't separate out stance and swing for these kids.
Yeah. And one of the other, I suppose, main themes that was derived from these discussions was the fact that the clinicians were often uncertain and needed more information to be able to make a decision around whether they thought they were, seeing those dystonic movements or not. Could you talk a bit more about the language that was used in those discussions about how uncertain they were?
Yeah, absolutely. So some of the language I don't know, or I just feel like I mentioned a little bit earlier, and I've pulled up the transcript now just to look up the word hard.
Yeah.
And, there are a lot of mentions of it. It was hard for me to decide, kind of hard to see.
Yeah.
It's hard to tell if that's dystonic. It's hard for me to be like, is that dystonic or is she just doing something else? I mean, a lot of the wording is describes the difficulty in seeing, in identifying dystonia in one context at one given point in time.
Sure.
Yeah.
And I think that the first figure in the paper goes over how initially we only reached consensus in 30% of the videos. After discussion, we hit 85%, but there's still that 15% that we didn't reach consensus on. And I don't want the takeaway message from that to be that 15% of the time experts don't agree on what is or is not dystonia. But I do want the takeaway message to be that if in practice, if you don't see dystonia in the first visit, that doesn't mean you should stop screening for it.
Such a good point.
Yeah.
Yep.
Because it shows up variably, right? By definition, it comes and goes depending on the trigger.
Yeah.
The first visit, the child in front of you is probably going to be really uncomfortable and really scared to see a new person. And so maybe they'll be tight the whole time.
Yep.
And you won't be able to tell that tightness is dystonia because it doesn't vary.
Yeah.
And then in that second visit, you see that it is quite variable and it is triggered. And all of a sudden, a child that you classified as spastic, purely spastic CP on visit 1 reveals their dystonia on visit 2.
Yeah.
So I think a lot of the uncertainty we expressed represents the need to stay vigilant for dystonia longitudinally in our kids with CP.
Yeah. And I'm sure that the 15% that they weren't able to achieve consensus on, there was still some really valuable information that was able to be derived from those clinical discussions anyway. So how do you think clinicians might be able to best use that kind of consensus building discussion in their within their own practice? And what would you recommend as tools to use to kind of build those discussions?
Right. Sorry. And let me just clarify, tools to build the discussions within clinical practice, or how to apply the results of what we gleaned from the discussions in clinical practice.
I think, I suppose, what tools do you think need to be available to be able to generate those discussions? So should clinicians be taking videos? How long should those videos be? Or, what kind of information do they need to be able to generate those discussions?
Got it. Yes. Thank you for clarifying. I appreciate that. Okay. So, yes, I think videos are helpful. I am almost evangelical about this, I would say. So in any sort of context where someone asks, how can we identify dystonia amongst this patient population or subject population, I am invariably the person that shouts videos. I think it is incredibly useful. I think that even the best and most seasoned clinicians could theoretically miss subtle dystonia if you're looking at just that person in that one moment in time. I think that if you if you're unsure about the movement phenotype that a person is displaying, having multiple people discuss the same video of the person doing the same thing can be really valuable. And it also serves as a bank for how that person's movements evolve over time. As you see them, if you keep taking videos, you can see what the changes are, what treatments do with regards to how a person moves over time. Videos are essential.
And it's such a simple thing, isn't it? It's a simple thing to be able to do.
It's simple. I mean, it is simple, but I don't want to downplay it. I mean, it takes time, right?
Of course.
You have to have somebody who's willing to take a smartphone or an iPad or something out to a hallway and videotape someone walking or doing the same thing.
Yeah.
So I guess integrating it into your clinical practice, it's still one extra thing.
Of course.
And in a monetary based medical world that I think we are maybe more intimately familiar with in the United States, it can be difficult, but it is incredibly valuable. And I think a lot of cerebral palsy centers are doing that as a matter of course now.
Mm-hmm.
Now, before we sort of finish up, I really want to talk about the area that really caught my eye, and I really want you to sort of talk me through it a little bit more about the selective dorsal root rhizotomy, that you had these quotations of people who were reviewing the video saying, I just feel like a lot of our rhizotomy patients will have a gait that looks like that several years later when they get bigger. Can you just contextualize that a little bit more for us? Because that's a really curious point for me.
Yeah. Yes. I think it's difficult to describe in the context of these videos, but I think that it is sometimes a gait that's somewhat weak can look variable just because of the weakness in the legs.
Sure.
But isn't necessarily dystonic. So I think that was a discussion that was had for several of the videos.
Yeah.
These are children that seem to have a little bit of a crouch, were flat-footed, maybe a slightly wider based gait. And, every once in a while, maybe there was some variability where one leg seemed to give out a little bit. And the question, but that specific type of movement was so atypical for dystonia that we see that oftentimes a comment was made, I wonder if this kid, if this is a post SDR kid that has a little bit of intermittent weakness manifesting in their gait.
And you do see that, like when you describe that, and it was nice to read it because I have seen that where there's weakness, but it's because there's no spasticity where you normally see like much more upright posture, you see a bit more crouch, so then you see the foot turn in a bit more sometimes. You go, oh, is the dystonia coming through a bit more because of the weakness and the spasticity is not there? And so it was just a good point just to bring up, I think. So thank you for going into that.
Yeah. And look, I think we could talk to you about this paper and the ideas within this paper for a couple more hours, but we won't keep you for that long. So I just wanted to kind of wrap up this discussion of the results of the paper with getting your insight into what your recommendations might be for future work in this area.
Absolutely. So we're working on part 2 of this paper now, actually. So we're looking at discussions of upper extremity movements in kids with spasticity and cerebral palsy and trying to characterize what the features are that experts cite when they're diagnosing dystonia of the upper extremities. So we hope that comes out soon. We also did this paper in a very circumscribed patient population. So these were kids that were independently ambulatory, GMFCS 1 to 3, kids that had cerebral palsy, spasticity, PVL on their brain MRIs. So this isn't all comers by any means. And we would love to expand this to a broader population of people with cerebral palsy, with the caveat that because dystonia can look different depending on the population of people you study, we would still have to bin these subjects into somewhat similar groups in order to characterize dystonia within each of these groups. But that's what's in the works.
Yeah, that should keep you busy for a little while.
Well, that is exciting to know that's coming up. Well, thank you so much, Bhooma, for that discussion. Just so many great take-homes. So now we have the great segment coming up next, which is called Tell It to Ed. Now, Ed, as you know, is our producer, and he doesn't have a background in child health, but he does listen in on all of our conversations. Like we keep saying, everyone's loving this segment. But this is a great opportunity to be able to describe this research in about 60 seconds or so, Bhooma, about what your work is to someone who doesn't have a background in child health. So take it away, Bhooma.
All right, Ed, here we go. Cerebral palsy is the most common motor disability of childhood, but motor disability can mean a lot of different things. One of the things it can mean is a form of motor disability called dystonia, which is variable, meaning it can look different based on the person, based on how they're moving, and it can be really hard to diagnose. Diagnosing it is very important because the treatments for it tend to work best if they're done early and can be very different from treatments for other forms of motor disability seen in cerebral palsy. So it's important to diagnose it. The problem is the best way we have to diagnose it right now is a bunch of experts getting together and talking about it in a room as they look at a patient or a video of that person moving. And that restricts the availability of a dystonia diagnosis to places that have access to a bunch of experts that are able to talk about these people while sitting in a room. So because we want everybody to have access to an accurate dystonia diagnosis and access to be able to make an accurate dystonia diagnosis, what we did was record these experts as they're having discussions about whether or not people with cerebral palsy have dystonia. And we broke that discussion down into the key ideas that they said were most important for diagnosing dystonia in people with CP. And the paper outlines those ideas and shares them with the world with the hope that everybody can be a part in some way of these expert guided discussions when diagnosing dystonia. And so they know that what these experts are saying when they make this really important diagnosis. So that's the hope. Fingers crossed. That's great. The goal of the paper.
That is wonderful. Thank you for that summary, Bhooma. All right, over to you, Ed. Do you have any questions?
As usual, I do have lots of questions. I was following this quite intently. So, yes, I do have my tablet with me, taking a couple of notes. Obviously, this is a very highbrow discussion. And I'm doing very well just to kind of get to this point, I think.
Well done.
But I guess I'm really interested in about the whole gaining consensus part. You said that after discussions, you kind of got to the 85% mark. Mm-hmm. I've got a small background in IT. So my question is technology related. Is there any technology or things like AI or machine learning with regards to the videos that are being taken that could help with gaining a consensus or new insights into dystonia?
That's a great question.
Oh, wow.
And I feel like I planted you're a plant. There is, and I'm actually working on it. So there was a platform presentation I gave at AACPDM on exactly that. There's a machine learning technique, a supervised machine learning technique that can be used to label videos, smartphone quality, iPad quality videos that can be acquired in 2D that you might easily be able to do in a clinic. You can label parts of the body using this supervised machine learning technique. And then a lot of the features that we identified in this paper, you can use that technique to then quantify. Mm-hmm. And we've shown that those track quantitatively with expert graded severity of dystonia and with dystonia period. Your question is a little more nuanced, which is, can you, I think in an unsupervised way, kind of feed a machine videos, say these videos are dystonia, these videos are not dystonia. Machine, can you give us the features that differentiate these two groups, correct? Is that?
I think so. That's my simpleton kind of thinking. Yeah.
No. I don't think that's simpleton thinking. I think that's a really great thought. I think that the N for that would have to be quite high. Mm-hmm. And I appreciate unsupervised machine learning approaches, but I fear that a lot of the output from research that goes that direction are variables that don't necessarily reflect how clinicians actually diagnose dystonia, if that makes sense. So you might have a group of videos that are identified as by clinicians as having dystonia and then not having dystonia. And let's say that the features picked up by an unsupervised machine learning technique is a facial grimace that is more frequently, and I'm making this up, but a facial grimace that's more frequently present in people with dystonia that's indicative of pain, but not necessarily indicative of dystonia, but is more tightly correlated to the dystonia videos compared to the non-dystonia videos. So that feature may be associated with dystonia, but isn't actually dystonic, if that makes sense. So I tend to move towards supervised machine learning approaches to label concrete features on videos and then use techniques like this, thematic analysis, to derive exactly what it is clinicians are saying to diagnose dystonia, and then using the supervised machine learning to, in a hypothesis-driven manner, quantify those features. Does that make sense? Did I answer your question?
I think so. I think computers can't be trusted by themselves.
Yeah, that's probably a better way of putting what I just said. Yeah.
You lose a lot of the context, don't you?
Yeah.
You know, the whole bigger picture if you're asking a computer to make a decision.
So Skynet, stay away. So a whole futuristic question. Hey, that came back again. Well, thank you, Ed, for that really good question. It really gets us thinking. And for everyone who's been listening, remember the run sheet notes are available on our website, researchworks.net. And of course, if you want this recorded as part of your CPD requirements, there is a form that you can fill out so you can keep this record as part of your PD. Well, thank you, Bhooma, for being on the show today. We have absolutely loved this discussion, and it is very true. We could keep talking to you, which we probably will a little bit offline.
But in the meantime,
this was a blast. Thank you, guys.
Thank you for joining us, and we'd encourage everyone to go and read your paper. And also, there's a really nifty YouTube video from developmental medicine and child neurology where you explain and give an overview of the study in a really user-friendly manner. So I'd encourage everyone to read the paper and watch the YouTube video and,
fantastic.
learn more about this paper.
All right. Well, thank you, everyone. Thanks for listening, and we will talk to you again next week. Bye.
Bye.